Thank you, David. It is a pleasure to be here in Louisville. Did I say that right? Louisville. Okay, I don't quite have it right, but at least I'm not saying Louisville or something like that, right? Right. It's a pleasure to be here in Louisville, even with the rainy weather. That's okay. No problem here. So, we're going to talk today about allocating resources during a pandemic. This is, as you might imagine, kind of a hot topic these days. It has been since H1N1 surfaced. It's actually, it was brewing below the surface before then, because there are a lot of concerns about avian flu and whether the likelihood or the possibility of avian flu mutating or combining with seasonal influenza to produce something that would rage through the human population as well. So the issue that I'm going to talk about today is the following. During a pandemic, or really any other public health disaster, I'm using a pandemic as kind of a case here, but a lot of these issues apply to other kinds of public health disasters, including natural disasters. The need for limited healthcare resources and services will greatly exceed supply. There are lots of other ethical challenges during pandemics and in preparing for pandemics, including professional duties to work. It's estimated that as a third or more clinicians may not show up for work, either due to illness or reluctance to become ill. There is also the issue of social distancing or other restrictions on individual freedoms and efforts to control contagion. And I understand that recently in this area there was a school closed in part because there weren't enough students showing up to have classes, but in this elementary school also a concern to try to contain further spread of the flu by closing the school at least for a while. And in Michigan last year we had also some school closings as a result of a sort of small, relative to a pandemic, small number of cases, but concerns about trying to control the transmission of the infection. So restrictions on individual freedom, which I'm not going to talk about today, except I just did, but that's also another important ethical challenge during and in preparation for pandemics that needs to be addressed. And also individuals' responsibilities to protect others. Hand washing, voluntary quarantine, something that surfaced recently is whether organizations or states can require people to be vaccinated against seasonal influenza, for instance, especially if they are healthcare personnel. So, influenza, seasonal flu. Don't forget seasonal flu, right? Seasonal flu affects 5 to 20% of the U.S. population every year. It's responsible for 200,000 hospitalizations, 10 million or so outpatient visits, and 35 to 45,000 deaths every year. Most of the deaths are among those who are old, immune suppressed, or otherwise sort of at risk for complications from the flu. And the seasonal vaccine can prevent some, but not all, illness. A pandemic is different, and forgive me, those of you who are clinicians, and especially those of you who might be much more versed in infectious diseases than me, I'm doing this because I don't know that everybody has that sort of a background, so I'm just kind of describing this so we're all at the same page. So pandemic is different than seasonal flu. In a pandemic, there's little or no sort of baseline immunity in the population. They tend to occur about every 20 to 30 years. They result in illness in between 25 and 40% of the population, so much higher than seasonal flu. And the mortality rate also tends to be higher than seasonal flu, depending on the pandemic, 2 to 3%. You may have more mortality in the young and the healthy, unlike seasonal flu, which tends to cause greater mortality and deaths in older folks and those with underlying illnesses. And importantly, and actually this slide's out of date, the anticipation was that we wouldn't have a vaccine for 4 to 6 months after the virus showed up. It turns out now that that's not the case, but the issue is we may not have vaccine, in fact we don't have vaccine at the onset of this influenza showing up in the population. So for H1N1, there's a vaccine out there, it's in production. The best guess is that we'll be getting it sometime in October, but we're already seeing H1N1 flu in lots of different places: Kentucky, Michigan, Texas, Georgia. So we don't have vaccine now. So if the H1N1 sort of ramps up and starts really getting widespread, and particularly if it gets more severe, the vaccine may not be able to really help us. So again, so we're talking about H1N1 a lot, but let's hope that we can learn some lessons and apply this to other possible pandemics in the future. Avian influenza, or H5N1, currently infects birds. There's been some human-to-human spread, and there's no vaccine, but it hasn't really taken off in any substantial way. So H1N1, which we've talked about a bit, source isn't completely clear. It's certainly not solely swine. The center of outbreak was initially in Mexico. Obviously, there's human-to-human spread. There actually, again, this is out of date as of like, what, a week or two ago they said they have a vaccine. There is vaccine now, but the mortality rate has actually been fairly low. Similar to other pandemics, the infection has been primarily in young people. In fact, college campuses have been really prime areas. Oh yeah, we're on a college campus right now, aren't we? Oh dear. College campuses have been prime areas for spread of H1N1, but the mortality has been, the severity of the illnesses have actually not, I mean, obviously there are exceptions to that, but compared to other pandemics, the severity hasn't been as great as expected. So, resources to provide health care, to provide health services to people, are already limited. Many hospitals and intensive care units operate near 100% occupancy, especially ICUs. Emergency department wait times can be long. Don't know what the situation is in Louisville, but in most sizable cities, ERs are crowded. Waiting for diagnostic scans for non-emergent issues sometimes can take a while. Again, that varies a lot from place to place, institution to institution. Waiting to see a specialist for non-urgent issues can be weeks or months. Again, varies a lot, but this can happen. Hence, the unbearable inevitability of healthcare rationing. That is, not everybody can get what they want when they want it. And this is the baseline. This is the status quo. This is what we have without a pandemic. So there are scarce resources, and then there are really, really scarce resources, okay? Obviously, there are countries that fit this bill, but in the U.S., in a pandemic, we will need more. Because there will be more sick people, we'll need more personnel. We need more doctors, nurses, respiratory therapists, delivery workers, manufacturing workers, particularly for vaccine and antivirals, public safety personnel, first responders, etc. We need more equipment and facilities: masks, gloves, ventilators, beds, oxygen. We need more medicines, antivirals in particular, but also antibiotics. We have a paper coming out soon on, in fact, allocating scarce antibiotics during a pandemic, which is not something people talk about that much. They are always focused on the antivirals, and vaccine when it's available. We need more community resources for those people who are homebound and or quarantined. They need somebody to bring them food. Okay, they may need someone to help care for them. We need some way of taking care of children, particularly if the schools are closed, and particularly if their parents or caregivers, whoever normally watches them, has to work. This is one of the issues that's come out in some other research we've done looking at public views on social distancing, is that people say, well, if you close the schools, then I have to stay home from work. So if I have to stay home from work, then I'm not earning any money, or you don't want them to stay home from work because they work in a hospital and they might be needed. So, or they work in a grocery store, something else that's kind of a key social function issue. So we need more of that, and we will have fewer personnel from illness and from fear of contagion. Again, it's estimated that at least a third of clinicians will not be available to work for one of these reasons. So that means we won't be able to adequately staff the beds and stuff we have now, okay, that are operating at near 100% capacity. And we'll have fewer community resources for the homebound, the quarantined. Who's going to go make a whole bunch of home visits during a pandemic, you know, right? This is taking on personal risk. There may be some people willing to do this, but there will be some people who don't. So this is just kind of an illustration, I won't spend a lot of time on it, of what sorts of things you'll see if you have a pandemic. So depending on what the infection rate is, which can vary depending on what the pandemic is like, and that sort of evolves over time. And also to some degree, the degree of severity. So one of the things we found with the H1N1, at least last year, was that although the infection rate seemed to be reasonably high, the severity wasn't that great. So you really didn't need as many ICU beds, for instance, as you thought. So if the yeah.
Population of how much?
Oh, so this is a population of just over 100,000. Okay. Was that it? No. No. This is actually this is a catchment area for the U of M hospital. So I'm not sure exactly what the number of population would be. So if your infection rate is 10%, they're anticipating you're going to have 44,000 phone calls, 30,000 outpatient visits, about 10,000 to the flu clinic, 11,000 plus ED visits. You'll need IV infusions for 15,000 people, and you'll have 8,000 people admitted to the hospital. And who knows intensive care, because that all depends on the severity of the particular type of infection you're talking about. That's a fairly low infection rate for a pandemic. You know, if you get up to 25%, which is probably more typical, you've got much higher numbers. You're talking about now 72,000 outpatient visits as a result of the pandemic. Add that to what's going on now. You're talking about 20,000 admissions to the hospital on top of what's going on now. So there's no question that we will face, if we have when we have a pandemic. I'm not saying it's this year. I'm saying we will have it at some point, because we do. We'll face severe scarcity, kind of like my little pictures here. So what will happen is not everyone who wants something will get it. Antivirals for the worried well, you know, the people who call and say, Doc, could you give me some Tamiflu? You know, I think maybe I saw somebody in the grocery store the other day who sneezed, okay? Or for those who have really been exposed. So they have someone they work with or they live with or they shook hands with the other day who was diagnosed with influenza. What about masks? For everyone? I mean, during the SARS outbreak, we saw this in Toronto and Hong Kong, everybody walking around masks on all the time. Certain kinds of masks, in particular, more high-tech ones than what this little bear is wearing here. Okay. Vaccine, when it's available. Now, not everyone wants vaccine, but may have more people wanting it than we have available. And then also reassurance, personal tension, just getting checked out. I think, David, you were saying something earlier today about how, you know, in some places they're saying, actually, you know, if you think you have the flu, just stay home. Don't come to the doctor. Which is kind of a strange thing to say to people, right?
Worst case scenario, everyone's sick.
Right. Everyone's sick. Don't come to the doctor, because you'll just get more people sick.
Not only that, it's also predicated on the antivirals already being running out.
Mm-hmm. Right. So, but even people who aren't sure, maybe they've got what they think is a cold, but it could be the flu. Should they go to the doctor? Should they not? Etc. So not everyone who wants something will get it, and not everyone who needs something, with our usual definition of need, will get it. At the peak of a pandemic, we might have 1 ICU bed for every 4 people who need one. Okay, now pandemics they ebb and flow. They're not as bad at the beginning, then they get bad, then they kind of go away, then they kind of ease off a bit, and then they get bad again, typical pandemics. We may have 1 ventilator for every 2 people who needs one. Those are just some examples. So how do you decide, how do you ration care justly in a pandemic? You know we get to the ethics piece sooner or later. Yes?
Let me ask a question as we go here.
Yeah. Feel free, anybody, anytime, by the way. Yeah.
How severe care will persons who actually contract H1N1 need? For instance, the reason I ask that is that we had 2 children here in Kentucky who contracted the flu, and they were both in ICU care. One is apparently going to do well, but still looks,
Sick.
Press care.
Okay.
And the other one is not doing well. Likely will not survive. Now, those are two illustrations. Now, how severe can we expect
H1N1 to be?
If they contract H1N1?
So H1N1 in particular is expected to hit young people, children, and the question is, how severe can we expect H1N1 to be in terms of disease severity for people who do catch H1N1 influenza? And I think the question is, we're not sure yet. Last year in the United States, the severity of illness was actually much less than in previous pandemics. And in fact, although slightly more severe than seasonal flu, and affecting different populations, as is typical for pandemics, not nearly as severe as pandemics usually are in terms of the severity of illness. We don't really know whether that will remain the case as H1N1 spreads. It may remain a fairly high infection rate, younger populations, but not usually a severe illness. Now, when I say not usually, that doesn't mean people can't get really sick and wind up in the intensive care unit or need a ventilator. Of course they can. It just means that compared to other pandemics, many people will have mild illnesses where they won't need hospitalization, ICU, etc. So, but we don't really know whether that will continue to be the case for H1N1. And let me remind you that even though there was a lot of it really wasn't as severe as we thought, it was still more severe than seasonal flu. Has been.
In what way does this virus differ from the one that was supposed to get in 1977?
1977.
Swine.
Okay. Oh, yeah.
We all lined up at
Great swine flu debacle.
assistance to get our swine flu vaccine.
Right.
We had people, movie stars and others, advising us to get it quickly.
Right. So the question for repeating for the web streaming is, how does this virus differ from the virus that was supposed to hit us in '77, which was a swine flu where everybody got vaccinated and there were problems associated with the mass vaccination going on then? And I would say, I don't know, I mean, one of the things about pandemics and in planning for pandemics, particularly as they start to occur or a new virus starts to enter a population, is there's a lot of uncertainty. So in fact, there was a fair amount of criticism about public health responses of being sort of overly paranoid in response to H1N1. And I said, okay, so if you're a public health director or something, and you're in charge of making sure that the health of the population is protected, et cetera, and you're just starting to get cases of a particular influenza that nobody really knows that much about yet, would you rather they be overly paranoid or underly paranoid, which is really bad grammar, but I think you get my drift, and that is, I would rather have them warning us too much, telling people to stay home if they're sick, washing their hands. There were some, school and whatnot closures that maybe were unnecessary in retrospect, but retrospect is always an easier judgment than prospectively. And if your community is getting hit with a new virus, and you're the public health director or whatever in charge of deciding when things start needing to close, I might want them to be a little more protective, personally. As we learned, so one of the things that happened is then we learned that the H1N1 wasn't as severe. Okay, and then people said, oh, well, maybe we don't need to be quite as careful as we thought. But, that can change, too. So, did I answer your question?
Yes,
a little? Some of it, anyway?
About mutations and viruses.
Oh.
Was the 77 one that they anticipated? H1N1?
No.
Wasn't the same?
No, that was, I believe, a swine flu only. And H1N1 has some swine components, but it isn't totally swine flu. But I have to say that I'm not an infectious disease specialist, and so you've just reached the limits of my knowledge in that area. We had another question.
I was wondering if we gained any information from the South American flu season that we just had.
Right.
Was it very severe?
So yeah, I mean, it was. So one of the issues we ran into as H1N1 came to the U.S. from Mexico last year is that the information from Mexico was sort of incomplete. It seemed to be much more severe than it was, probably because there were a lot of people infected that weren't documented or counted or seeking care or whatever, because they have a very different type of health system than we have. In South America, I think they have found so I think it was not as severe as we initially thought based on initial Mexican data. I think it was slightly, and I don't know if somebody knows the accurate answer to this, let me know. My understanding is that severity of illness was worse there than we found in the U.S. Last year. I'm saying last year, knowing that actually there's been H1N1 present in the U.S. consistently and continually, but there was sort of a peak of infections. There were some still sort of remaining, and it's starting to go up quite a bit again. So, all right. Other questions? No. Okay, so now we get to one of the problem that I initially stated, which is that if you don't have enough stuff and you have people who not just want but also need more than you have, how do you make those decisions? How do you decide? How do you allocate resources during a pandemic? So I want to emphasize that this is different from rationing justly during regular scarcity. So we always have scarcity, all right? We don't have enough beds or ERs or primary care docs or MRI scanners or medication or whatever. But this is a little bit different because it is a particular kind of situation, and we'll go into that a little bit more. There's a greater emphasis on the utility principle for just rationing, or the greatest good for the greatest number. So this is something that is tempered a great deal in normal scarcity considerations. So we don't just say that's how we always ration health care, is the greatest good for the greatest number. But we take into account compassion and relief of suffering and some other things as well, and also distributive concerns and whatnot. But there's a greater emphasis during a pandemic on this, and importantly, a need for clinicians to temper their advocacy. So one of the jobs of a doctor or a nurse normally is you're looking out for your patient, all right? That's your job. You're supposed to do that. That's your role, and you're required by your professional ethics, in fact, to advocate for what your patients need. So during a pandemic, you have to temper that. You have to recognize that there may be other patients with greater needs or greater claims than your patient or patients. So, in developing a plan for allocating resources during a pandemic, you have to pay attention to this professional ethics, because you still want it to work. You still want professionals to be ethical. So they have obligations to individual patients. They also have obligations to society. They have obligations to be competent and know what they're doing, to know, for instance, what the current update is on the flu response in your own institution, etc. To be honest and transparent. So not telling someone, well, you don't need a ventilator, you don't need an ICU bed when they do need it, but they're not meeting the criteria for it, say. And advocacy, which in this case will be tempered by obligations to the health of the public and to community obligations as well. Institutions also have ethical obligations to individuals, to their communities. So by individuals, it means those they have responsibilities to, generally speaking, and important obligations of competence, including planning and supervising any kind of allocation scheme. So it's important to plan ahead of time. In other words, you don't wait until the pandemic hits and go, oh my gosh, we don't have enough beds, oxygen, therapists, nurses, doctors, whatever. Now what are we going to do? You want to plan that ahead of time and decide what sort of decision-making process you're going to use, what kind of criteria you're going to use, et cetera. And then during the pandemic, to make sure that that plan is adhered to so that people aren't gaming the system or otherwise sort of undermining it. That would make it less fair. And again, obligations of honesty and transparency. So being clear with the community that we don't have enough ICUs to take care of everybody, or, you know, we have or we don't have the vaccine in yet. We don't have antivirals, and these are the people who are going to be first in line for them, et cetera. So, sorry. A fair distribution of resources should, for the most part, provide equal treatment to those who are, in morally relevant ways, equal. So you got two people about the same age, about the same health status. They should get pretty much equal treatment, and it shouldn't matter that one of them, you know, is married to the president of the university or something, okay? You know, so that kind of sort of social influence really shouldn't be coming into play. You want to, as much as possible, maximize benefit from the limited resources you have. This is that utility principle operating. And importantly, and I've actually been rethinking this a little bit, because in our planning we said you can't remedy the existing inequalities and disparities in health status, health access, access to service, et cetera, but you at least should not exacerbate them in whatever your response is and how you decide to allocate resources during a pandemic. I actually have been rethinking this a little bit and thinking maybe this isn't strong enough. Maybe we actually should be folks who have natural disadvantage, who naturally have less access to care, should perhaps receive more preference or more priority because of that. The assumption being that, you know, they already have 3 strikes against them when they show up at your door. So I don't know. I'm going to leave it as is for now, but just to let you know, I've been mulling that one over. And also importantly, in planning and in implementation, to make sure that there are fair processes for decision making. And I would argue that this includes public input and public engagement on the question. This is something the CDC has done to some extent, and our community has done to some extent as well. That is, when you're planning that rationing scheme, how you're going to decide who gets what during a pandemic, to take that plan out to the community and say, hey, this is what we're going to do, what do you think? And to take their comments seriously and incorporate them into those planning decisions. I think one of the reasons to do that is a very practical one, and one of sort of buy-in. That is, you're not just springing it on them when the pandemic hits and everybody's already panicked anyway. That's one of the ways sometimes you can sell this to the folks who are maybe more reluctant to take these kinds of questions to the public. But in terms of accountability of decisions, in terms of justifying decisions that will result in death for some people who could otherwise be saved if it were not due to scarce resources, I think the accountability that results, the justifiability that results from having the public engaged in that process, participating in those decisions, and having input to those decisions is very great. Ah, that's the, yes?
Well, I have a question.
Yeah.
You may get to this later, but what have you done in your community to make the population aware of these decisions that might need to be made?
Uh-huh.
Have you done anything?
Oh, yeah. Oh, yeah. So, and, you know, different, I'm not going to rely on just our own. So the question is, you're supposed to yell at me if I don't repeat the question.
Susan, repeat the question.
Yeah, thank you. So the question is, what have you done in your community to take these kinds of issues out to the public and tell them what might happen in the event of a pandemic? And so I'm going to answer you with what we're doing, but I'm also going to say that, you know, that's one little community in a whole big wide world, and that there are lots of other places, you know, doing things as well. So in Washtenaw County, which is where the University of Michigan is, and many other health care organizations as well. We have had some public forums on the topic, which have been surprisingly calm, actually. So on the issue of, you know, hey, we're just not going to have enough ventilators and antivirals and stuff like that, this is what we're proposing to do. We're proposing using a sort of modified clinical prognostic indicator for deciding who can be admitted, say, to an ICU and receive a ventilator. And there's a time limit on that, and if they don't improve, and it's all, you know, anyway. So, of course, this, right, the death panels. Thank you, Dave. I'm never going to, right, thank you so much. This is out on the web now, isn't it? Yes, great. So, so we have taken both some of the, I mean, we haven't taken the final document because, frankly, we just finished it not that long ago to the public yet. But we've had meetings, public fora, and meetings also with our county health department. Has a very strong relationship with a number of community organizations and groups, and has a big sort of community committee that we've also taken some questions to. So it's been sort of a process over time.
But kidding aside, you've not had any pushback by people saying, you mean I'm not going to get a ventilator someday?
You know, I actually was, now, this is, of course, in the planning process. You get into the actual, you know, wait a minute, now you're talking about me, my kid, my husband, whatever. I don't care what I said at that forum 3 months ago, right? So, you know, the forums and the public input has been surprisingly calm, reasonable, and accepting of the need to make limits. And I'm worried about that, actually, because I think they should be more concerned about it. I think they should be raising tougher questions, actually. So that actually worries me. Now, that's at home.
So how many forums did you have, and how many people came, and what's your population? And does your university actually have a plan, or you're just working on it?
Okay, no, we have a plan. We have a scarce resource allocation document that addresses a variety of types of resources, so antivirals, antibiotics, oxygen, ventilators, blah, blah, blah. It lays out an ethical framework. It lays out a sort of, there's a sort of algorithm, clinical algorithm based on prognosis a lot, but there's also a scarce resource allocation committee that's charged with allowing exceptions to that for unusual cases. And then there's sort of a very strong process in terms of who's making what decisions when, who can bring appeals, and all that kind of stuff. So that's our plan. And we have it, and we haven't, like I said, we haven't taken the final thing to community meetings yet, because it hasn't been around that long. We have taken it, however, to the state, because the state is actually doing some similar planning statewide. They'd like it to be consistent. That's another issue, actually, and an important justice issue is, so if, say, U of M health system has this process, but St. Joe's at the other end of town has something different, can I just go from one to the other to get what I need or want? So the state is looking at this also, and regions are looking at it. We're working with, like, the Southeastern Michigan, so that there's consistency between how different institutions and communities decide and allocate resources.
She also asked specifics of how many forums.
Oh, how many forums have we had?
How many attended, on average?
I don't know. I don't know that I can answer. We've had it, I'd say, I don't know, formal forums, we've had at least 4 or 5. We've had also, though, some meetings with that community committee I told you about that's affiliated with our county health department, and we've gotten feedback in other ways, sort of on an ongoing basis, both from them, mostly from that committee, which is used to weighing in on public health stuff. And it's a very diverse group, by the way, and heavily represents the disadvantaged members of our community, so it's a good thing. Yes?
Whenever we start talking about allocation, it tends to cause self-interest to surface. And And in the worst possible scenario, rationality is going to go out the window first.
Mm-hmm.
Has your committee anticipated the problem of panic, general panic?
Yes.
And how are you going to deal with it?
Let me repeat the question. During a pandemic, rationality may go out the window, self-interest may be running rampant, and has your committee considered the issue of panic? And my answer was yes.
And?
Oh, there was something else? That was a yes or no question. Actually, later on in this talk, I'll be showing you quotes from some of the public forums and focus groups we've run in which people talk about that very self-interest thing. It's very interesting. People are worried about that. So the less powerful you are in society, the more worried you are about it.
That's right.
So, okay, let's see. Where are we? Okay. So, professional ethics. Even the most detailed rule-based scheme, so you can have like, dot all the I's, cross all the T's for allocating scarce resources, ventilators, antibiotics, whatever, will still require clinical judgment. Because there are always exceptions. There is no 70-kilogram man standard, typical patient, right? And all the sort of, this is why we have clinical guidelines instead of clinical, rules you have to do it this way. Because patients don't fit things very well all the time. So you still need clinical judgment. You want doctors and nurses to use their clinical judgment. Wait, this patient doesn't seem to fit this very well, or this one's doing better or worse or whatever. But you also don't want them to misrepresent their clinical judgment to help individual patients, because that undermines the fairness of the whole program. Okay? So if you have a doctor who says, don't worry, Joe, I'm gonna, I'll just change your vitals or labs around a little bit, or I'll, say I found this on physical exam or something like that. You just don't want people doing that. Actually, I think this is okay. We expect docs and nurses not to misrepresent their clinical opinions when they fill out, say, disability forms or, pre-authorization requirements. I'm not saying they always adhere to not misrepresenting or exaggerating things a little bit, but I think for the most part they're used to this kind of an expectation. And importantly, and you would like to not even have to say this, but you can't use your position as a professional to gain access to resources for yourself, for your family, and for your friends. Institutions need to plan competently for disaster. They need to train personnel. So one of the issues is making sure that you have, let me back up. One of the reasons they need to do this is this avoid unnecessary rationing. So in other words, if you know you're going to be short respiratory therapists, okay, or ventilators or oxygen or whatever, to think, how could I minimize that scarcity during a pandemic, since I know it's going to hit sometime, okay? Maybe not this year, maybe this year. Can I cross-train some personnel so that the nurses who are currently working in, say, head and neck surgery could actually help take care of patients with flu? Okay? Could I train some people who do, physical therapy, say, and take them and teach them how to do some basic respiratory therapy stuff? Okay? So that's one of the ways that institutions can exhibit competence, which is an ethical obligation of healthcare institutions, is to do some personnel training, some equipment purchasing. A lot of places are stockpiling extra ventilators, masks, and stuff like that, and to all this in order to avoid or to minimize really the rationing that will be inevitable during a pandemic. So, and then and also to plan how will allocation happen. So to make sure that this planning happens, to communicate transparently about decisions both ahead of time and during the crisis, and to get public input on these questions of value adds legitimacy and enhances trust in the institution. So consistent implementation of legitimate rules. So if you have if you've gone through this process, you've developed what you think is a fair scheme for allocating resources during a pandemic, and then, the pandemic hits and everybody panics, and the rules go out the window, then the fairness has been completely undermined. And that's a failure of the institution, really. So what does distributive justice require in terms of a rationing plan or an allocation scheme? Well, first, you treat patients and communities equally when they're equal in morally relevant ways. So severity of illness is a morally relevant consideration, okay? So someone who is more severely ill or less severely ill, to take that into account in allocating resources during a pandemic makes sense, okay? More severely ill person might need something that the other person doesn't, or they might be so severely ill that they're unlikely to benefit from it, and so the less severely ill person gets the ventilator instead. The probability of survival with the ventilator versus some of the less relevant considerations or not relevant considerations, that would be social standing or even pre-existing patients, actually. And I think this is tough for those of us who see patients on a regular basis. This is tough. You want to make sure your patients get what they need, right? The idea that someone who's a pre-existing patient would get easier, faster access, perhaps, to something would come naturally to us, but we have to sort of guard against that, I think. Some questionably morally relevant considerations: age. So should age be taken into account? If so, what age exactly? This is something we've really struggled with. Our committee has really struggled with. And I can't say that we have a great answer. We think age is relevant, but we have a hard time drawing a line at a particular age. What about coexisting illnesses? Other than the fact that this contributes to prognosis, but what about it as sort of a quality of life issue? Sorry, what?
Since you're talking about specification, one of the things that I've been intrigued with is a concept which I call guideline plasticity.
Uh-huh.
And what you would need to do in a circumstance like this, because we don't know how prevalent the virus will be, how virulent the virus will be, and epidemiologically who will suffer most from it, that we may actually have to, for no better term, tinker with our guidelines, depending on the outcome. So for instance, if you find out that people over 70 have a 70% chance of survival, whereas people less than 20 have a 10% chance of survival.
Right.
If two patients of those age groups come in and you have to make a decision who's going to get it, you're going to have to really change how you're thinking about who gets it, who doesn't get it, based on the epidemiology and the specifics that you see of the patients in front of you. I mean, that's obviously going to also have some weight. But I was wondering, has there been anything in the literature about having what is this?
How things evolve.
Plastic, basically evolutionary guidelines, things that would be plastic and that would change according to the epidemiological circumstances. Right.
So his question was about the issue of guidelines or allocation schemes that can evolve as we learn more about the infection. How prevalent is it? How severe is it? Who does it affect? How does it affect them, et cetera? And and is there anything in the literature on sort of this guideline evolution or plasticity issue? I would say a little bit, but surprisingly little. And I think one of the things that most places have recognized it and hopefully learned, in fact, from last year's H1N1 infections is that you do need to evolve. So we created this, scarce resource allocation committee thing, and in part because not just as you learn more about the virus, you need to evolve your allocation schemes to adjust for things like prognosis in certain groups, et cetera, but also because the pandemic itself shifts over time, right? So, for instance, when do you say, okay, we got to start this allocation scheme now? Is it when you get the first 3 cases? Well, no. Is it when you have 30,000, you better have it in place well before that. So when in between exactly do you, and so one of the things that's in our guideline, in fact, is when exactly the Scarce Resource Allocation Committee starts to meet, that the allocation scheme starts to operate, and how it gets operated in sort of incremental ways. You know, so you may have like a peak infection and then it kind of tails off, and then you can ease up your allocation scheme a little bit. And then if it peaks again, you're going to have to tighten things down again. So it has to evolve, not just because we learn more about it, but also because the infection itself and how it affects the community is going to change over time. So, other questions about that? Okay. Sorry? Oh yeah, I want to get to those quotes because I promised you. All right, so one of the other issues is that we know current access to care and, in fact, health outcomes are unequal. And as I said earlier, we propose that allocating resources in a pandemic should not exacerbate existing inequalities. So it shouldn't contribute to worsening the inequities that our system currently exhibits. And for instance, if you have a first come, first served, so the people who show up first get the antivirals or the vaccines or whatever, that actually tends to exacerbate existing inequities, because the people who are knowledgeable, who have transportation, who have an existing source of care, et cetera, all those things contribute to getting better access in a first come, first served basis, and they would be more likely to get scarce resources than those people who don't have those things. So that was something we specifically recommended against. In a survey that was done, this was actually a number of years ago before H1N1 came around, 72% of Americans thought those with more wealth and influence would gain earlier access to the smallpox vaccine. Again, fear of this power and influence creating better access. Yes?
Smallpox vaccine has been given to children since, what, 1940? That was at a time when there was more inequity in our society than there is now. Mm-hmm. And so that would...
This was actually after 9/11, when there was concern about sort of bioterrorism, and smallpox was one of the, and there are a number of people who haven't been vaccinated against smallpox.
Well, they stopped in 72.
Yeah, so anyone born since then, pretty much. And so there are people who say, well, if I'm 70 years old and I was vaccinated as a kid, am I still immune? That's a big question too. So
it's just without a date in there.
Right.
I think
yeah.
When smallpox really ravaged the country, and
right.
But it has not since.
Right. So I'm sorry, I should have said clear. This was after. Yeah, this is when the concern for bioterrorism was pretty widespread, and this is when they did that survey, and it was in that context. Yes.
Play devil's advocate. What if those with the wealth and influence had also greater responsibility to the response effort to the pandemic? Should they be raised to a level of getting that medical resource first if they or their family members were?
Right. So the question is, what about those who have more wealth or influence if they are part of the response, the public response to the pandemic? So maybe they work in public safety or in the healthcare field or the utilities. So one of the things that's interesting is if you look at the priorities based on sort of assuring essential community services during a pandemic, healthcare workers, and not all of them, are part of that. But there's also a lot about communications personnel, utilities, grocery stores, delivery drivers, et cetera. And so I would say that I don't think power, wealth, and influence would necessarily eliminate somebody from getting access to things if they have a key role like that to play. No, they should be prioritized on that basis. And they are, in general, prioritized on the basis of whatever role they'd be playing during the pandemic. So the concern is that other than those sort of key personnel, essential functioning of society types of folks, then what? then who gets the antivirals or the vaccine, and actually for those playing a key role in the pandemic, and one of the things we put in our document was like, okay, once they need a ventilator, they don't get priority anymore because they're not coming back to work, chances are. And so it's not like a vaccine where you give the vaccine to all the healthcare workers first, so you have healthcare workers when the pandemic hits. Once they've gotten flu, it's a little late. Yeah.
If their family members contract the disease, how can they mentally stay in the game
Mm-hmm.
if they're constantly worrying about them? How can they contribute to the problem-solving system?
Mm-hmm. So the question is about folks who would be involved in community response to a pandemic and assuring the essential functions of society, including but not limited to healthcare providers. And what I think what you're asking is, would you prioritize their family members in some way in order?
The mayor and your kids got sick, how could you effectively, or the president,
right.
do your duties if you were constantly getting updates or not getting updates on the condition and the
right.
care that your kids would be receiving?
So, but are you asking whether or not you would prioritize, say, the mayor's kids or the police chief's children in order to enable the mayor or the police chief to stay focused on the job they need to do? That's a very good question. What do you guys think? I want to get to my quotes, but it's an important question. In general, where we came down on this, but it has varied across different communities, is no. And in fact, for some, particularly public employees or publicly elected folks like mayors, police chiefs, public health. I mean, the public health department they have to go to work. They have to have arrangements made so that if they have family obligations or other personal obligations, that those will be taken care of when they're needed for a public health disaster. That's an expectation of their job. So, okay. Also in the distributive justice area here, we keep getting sort of off on these really interesting tangents. Distributive justice also requires that we maximize the benefit from very scarce resources. This is the assure the essential functioning of society bit. Nancy Cass has a great article about this, including utilities, communications, deliveries, basic supplies like food, public safety, etc. Some healthcare workers, so one of the things we emphasize is that, okay, podiatrists, maybe not, right? Unless you can do something else during a pandemic besides take care of feet, you may not be in the priority list, okay? So it's not healthcare workers generally. It can be some but not all. And obviously want to reduce individual deaths and hospitalizations as well. Fair procedures for allocating resources include explicit, open, publicly available rationales in the planning, engaging the public in decision making. This is underlined because it's available online, Citizen Voices on Pandemic Flu Choices, and this was from the CDC, which has done some work in this. And during implementation, you need some kind of a mechanism for resolving disputes. Also, you need transparency and enforcement. So, these are quotes from some focus groups that were run by a public health graduate student of mine in several communities throughout southeastern Michigan. And she was asking them both about social distancing issues, which will be out in the American Journal of Bioethics in November, and also about resource allocation. And these are some of the quotes that I'll pull for your interest. The vaccine should be treated like a narcotic. It should be prescribed in triplicate. It should be locked up. That might cut down on some of the pilfering. I think this is that sort of self-interest, everybody's acting, looking out for themselves kind of thing. But an idea that you need mechanisms to make sure that what people want to do, which is, might be steal or weasel their way into getting something, that they can't do it. Okay? First and foremost, don't wait until the numbers start rising and people are dying from it before they, meaning government leaders, know the cause of what is going on. So there's sort of a government, public health in particular, public health arms of government in particular, need to keep track of things, need to know what's going on, and need to know when to start taking some action. Don't base it, meaning what people get, on somebody's insurance, how much money they make, on who gets the vaccine and who doesn't. I don't think a lottery would work. This is one of the issues raised by one of our group members, because say a poor person drew a number and a rich person didn't. Well, he's going to try to bribe that person. So this is the don't exacerbate existing inequities and inequalities in our system, that a lottery, which on the surface sounds fair, but would certainly lead to this kind of a result or outcome. It makes sense to vaccinate healthcare workers first so they can help everybody else. I think about that when you're on an airplane. When the oxygen mask comes down, you put it on first, and then you help your children. So people get sort of the logic behind making sure those who are going to care for others are taken care of first. Your electric company, your gas company, those people need to be taken care of too. So there was definitely a recognition that it's not just the healthcare workers that should receive priority for things, and the morticians. We need someone to take care of the dead bodies. Ah! I don't think we had this in our list. I know, isn't that like frightening? But yeah, you do need somebody to take care of the dead bodies. You can have a very, very sick 90-year-old who needs that ventilator, but someone who's 55 and in fairly good health needs it more. So this is that age question. Okay, 90, 55 sounds, oh yeah, okay. What if you're talking about like 80 and 65? Getting a little less comfortable there. Yes, ma'am.
What if you just reverse those?
A very, very sick 55-year-old?
Yes, and otherwise healthy 19-year-old. I think we get tied up with numbers and not the whole picture.
Okay. So what if you have a 90-year-old and a 55-year-old that are about the same in terms of underlying health status?
A very sick 55-year-old and a fairly good health 90-year-old.
No, I know. So that's what I have to repeat the question. So the question is, what if you reverse those? What if you have a very, very sick 55-year-old who needs the ventilator, but someone who's 90 and in fairly good health needs it more?
Needs it at the same time.
No.
Needs it more?
Just change what 55 where 90 is and 90.
Yeah, okay.
Needs it more time.
Okay, so what you're saying is, if the 55-year-old has what, sort of a not so great health status, is that what you're saying? Or maybe they're not really sick enough to need a ventilator? I guess I'm not exactly, I want you to make your point.
I want the 55-year-old to be very, very sick and need the ventilator.
Okay.
The 90-year-old not to be.
Not to need the ventilator?
Well, to need a ventilator, but not nearly to the degree the 55-year-old does.
Okay. Okay.
I'd like to see that age sort of not be prejudicial.
Okay, and so what you're saying is that maybe we should prioritize the 90-year-old because they're more likely to benefit from the ventilator.
Well, if the 55-year-old's not likely to benefit.
Right.
So if you have a 55-year-old, 450-pound man with chronic COPD who smoked 60-pack years, not unlike a patient I saw the other day.
Okay.
And needs a ventilator, versus a 90-year-old who actually has always kept pretty
swims every morning,
swims or walks every day and is in good health.
Yeah.
Both of which are stricken at the same time with the same flu. This is why I talk about plasticity. At this point there, you have to then say, that's why I was concerned about the final statement of, and needs it more.
But this is a quote, okay? This is a quote from one of our participants. It's not my point of view necessarily, okay? I'm just saying that the age issue comes up. And I think it's actually, if you want to take on the age issue, I think what you need to do is compare apples to apples. If you have equal people who are in equal need of a ventilator, who have equal baseline functional status, okay? Ambulatory healthy 90-year-old, ambulatory healthy 55-year-old. Both need a ventilator, both have the same probability of surviving with a ventilator. Should there be a difference in how they're treated? Yes, you got an answer to that?
Putting these things down house, so it's never going to be down to
The
there's
two people.
here and one bed which is going to get it. I think you need to decide about where age is in relevancy and where underlying health is in relevancy and assign weights to each. I see plenty of people who are 90 in the ICU and unventilate who typically extremely not well, and I think even now in our society we don't contemplate the role of age in ICU. That's a problem in society. But so I'm just thinking, when you get down to these binary questions like that, you can kind of get ridiculous paths because if we're only worried about 2 people, we're not dealing with the pandemic, right? So
Well,
we really have to decide what.
Actually, chances are what you have is you have an ICU that's full and lots of people in the ER who need ventilators and ICUs. Yeah.
So you just have to decide how does a 90-year-old do? That the weight of that person's age do in terms of, health.
So you would say use age only if age independently, that is absent other coexisting illnesses or whatever, predicts prognosis, survival, a likelihood of benefit, etc.
Things I look at when I'm thinking about prognosis. Age, nutrition, functionality, diseases, all kinds of things. So
Ruth does palliative care.
I do palliative care. So.
Okay.
But I'm not trying to kill Granny's disease.
You're not what? Not trying to kill. Oh no, death panels again. We're in death panels again. You know, the interesting thing that I found, and I've done a lot of work in not necessarily related to pandemics, but in other areas getting public views on resource allocation in healthcare. One of the things I find is that older folks actually say, you know what? It's okay. You don't have to give me that. Particularly if they can trade that off for something else that they find more valuable in old age that enables them to remain independent, living at home, et cetera, et cetera. So if we had a system that enabled us to make those kinds of trade-offs and people were, anyway, that's my other work. So another comment from one of our participants, I don't even know how to think about something like that, who gets treatment. I mean, there's a recognition that these are very difficult, challenging, morally, emotionally, and intellectually questions. So, and finally, one long quote from one of our participants incorporates a lot of good wisdom here. I think the best thing they could do now is plan now. Make a plan when it's not breaking out, so you can be more rational in your thought, and then write it down and educate people on what the plan is, get buy-in from people so the firemen know they're getting the vaccine or whatever, and what their job is. I think, too, in the midst of something like that, or even in threat, make sure everybody knows what the plan is and then follow it. Don't deviate based on emotion or, because you tend to get real selfish in the midst of it, but if that's the plan and you've agreed on it earlier, then I think the chance of keeping order is probably a lot higher. So make a plan ahead of time and stick to it. I didn't show some of these quotes, but there were quotes about people saying, oh, the politicians, they're going to be making sure they get what they need, that the people who work for the vaccine manufacturer, the antiviral manufacturer, they're taking stuff home. I mean, there's a lot of concern about this sort of, this self-interest, the selfish, looking out for myself and my family, and actually a recognition on a participant's part of, that's what people do. That's what I would do. I'm looking out for me and my family, so that's a natural thing that we should expect it. So those are the, yes?
Do you have any thoughts on how the government responds as far as quarantining an area or how they spreading?
Okay. So this is the question was about government responses, particularly related to quarantining or other kinds. Right. So as an example of that. So yeah, now remember I said at the very beginning this wasn't about social distancing, it's about resource allocation, but that's okay. I'll talk about it anyway. So yeah, I mean one of the many obligations and duties of our government, our public health offices and whatnot, is to make decisions about when to implement voluntary or involuntary restrictions on personal freedoms. So, example of a voluntary one, the sign in the elevator we're riding up. If you're sick, stay home. Okay? That is an example of a policy that says stay home if you're sick. In fact, at my university, not only do we have that being posted everywhere and advertised everywhere, but we also, those of us who teach classes, have been told by the administration of the university that if students are absent because of that they don't have to go get a note from the doctor, because the assumption is then they'll go to the health service will be overwhelmed, they'll make everybody else sick, et cetera, but they've been told to stay home and not go anywhere, so we should just believe them. Okay? And we, in fact, have been told that we have to do that as their professors. So, okay. So that's an example of voluntary quarantining or social distancing, if you will. There, of course, are less voluntary, that is, so school closures. Schools can decide that. Sometimes public health departments or personnel will make those decisions or recommend that schools close, et cetera. A lot of times it's actually communications between the two. So the schools will say, do you think we should close? No, I call the health department, do you think we should close? This is what's happening. And in fact, the public health departments will tell the schools, let us know what's going on, right? Especially with H1N1, because it tends to affect school-age children and up through college age and young adults. So it's been a prime source, so they're trying to keep track of what's going on. Then there's involuntary quarantine. That is, you're sick, you must stay home. You're not allowed out of your house. Well, that takes a much higher threshold of knowing that that is of benefit to the public health. And frankly, the data on social distancing is not strong. The best data is historical. I mean, we have public health people in this audience who maybe could speak to this better than I could, but studying you can't do really a sort of randomized controlled trial of social distancing. Nobody's going to do that during a pandemic.
Well, one thing that did happen during the 1918-1919 epidemic was one of the noteworthy examples. In Philadelphia, the city fathers decided they were going to go forward with the Labor Day parade.
Right.
So that way they could have as many people cough on each other going through the parade and who were in the parade as possible, so that obligingly many, many thousands of people then contracted influenza, and many of whom died. Later they then clamped down and shut the schools and closed the churches and that sort of thing. However, they kept the bars open. And so, I mean, there are things that are acceptable and those things that are unacceptable. And the real question, though, will be if we ever get to a point where if this virus or an H5N1 variant or a merging of the two became so virulent that you had maximum takedown, where you had 40%, 50% people getting it, but also of those, 50% of those dying.
So one of the things you'll see in this, we're talking about social distancing things, and especially sort of massive, government decisions about social distancing or about not social distancing, like go ahead with that Labor Day parade. So first of all, Howard Markel's article in JAMA about sort of looking historically at the communities where there were or were not social distancing policies in place is the best evidence that we have that it works. And that's, I mean, it's obviously not a controlled experiment. You just, there's all kinds of reasons why those communities might be different. But it looks like there's some effect. It may not so much prevent as much of the number of infections as it may sort of slow down from sort of the initiation to peak, and it may enable you to build capacity or get vaccine produced, which wasn't a possibility back during that influenza epidemic, but is in our current society. So the virulence is obviously an important issue there. There's also recognition, I think, amongst many folks that you have, it's not just, I mean, it's schools, it's public gatherings, it's workplaces, it's churches and religious institutions. And in the paper coming out in HJOB in November, you'll see that that was a real important issue for our participants, because they were like, well, but that's when you need it the most. You know, when you're in crisis, you really need that community. And other people are like, yeah, but you're going to go, you're going to spread it to each other. So there was a lot of controversy about that. Yes?
You said I have an obligation to my patient and to society.
Yep.
Okay, I'm in the clinic with a sick patient, needs an ICU bed. Find there's one available. I'm going to answer that bed. I don't know anything about society or who else is looking for that bed. That can't be my obligation at that point. Is there a benevolent dictator or something?
Who's the umpire?
Oh. Okay, so one of the things that we try to do in our system, and I'm sure in an imperfect way, is your job as the patient's doctor is to say, this patient needs a ventilator. Okay, they are, you know, they're failing in their oxygenation or whatever, but for whatever normal medical reasons they need a ventilator. So then we have folks who take all those requests, and then if you assume that maybe there's 20 requests for not 20 ICU beds, okay, or not 20 ventilators, which at the peak of a pandemic is likely to be the case. And there's somebody who says, okay, tell me about your patient. You know, how old are they? What kind of medical conditions do they have? What's their respiratory rate, their oxygenation level, et cetera, et cetera, et cetera. So if you know what criteria they're using on which to base their decision, you could fudge. You could, you know, well, the respiratory rate's a little bit faster than that, or, well, let's have them walk down the hall and then I'll check their oxygenation or something. You know what I'm saying, okay? Maybe not so much for someone who needs a ventilator. You can't do this so much, but you can fudge. You can emphasize things over others.
Well, let's say I'm not fudging.
Okay. You're going to be honest about the clinical information on the patient. Then there's a particular protocol, criteria that those judging who gets the ventilator use, and your patient may or may not fit those criteria. And if they don't fit the criteria, then at least in our allocation scheme, they would be prioritized for measures to make sure that they have the next best possible care and comfort. So oxygen, for instance, which people were talking about, I said, you know, the folks who don't get ventilators, you need to be, or those who are dying, oxygen is important for palliative care for many, many patients. And I said, you need to make sure that palliative care, that comfort measures are prioritized, particularly for those people who are unprioritized for the other stuff.
You're not putting me in the same class as a podiatrist, right? In terms of the sense of...
No, in fact, we will need more. We will need more palliative care providers because there will be more people dying.
It's a little bit like the early days of dialysis when we had 4 beds. We had a committee pick out the worthy candidates, and we had found it impossible. And
right.
The came along, and everybody got dialysis.
Right. Well, I don't think we have that kind of a solution for the case of a pandemic, but yeah.
55 and 90-year-old, there was no solution.
Yeah. So, yes.
A question. Is there an internal or publicized working document that deals with something like what Herman Collin called an escalation ladder? Certain trip points. First, you know, we've got enough to go around. If we reach this number, then these measures would be implemented. Anything like that circulating?
Well, we have that in our protocol, and I think others have as well. There are a number, by the way. New York, the state of New York has a whole document. The University of Toronto contributed to sort of pandemic planning document that's excellent. That I highly recommend. The CDC has a lot of stuff on their website also, and so we do. I haven't seen that in a lot of the literature actually, but sort of trip points. That is, okay, now we need to start using criteria for the allocation of ventilators, or now we need to start using criteria for who gets the antivirals or whatever. Yeah.
My question is, and it just occurred to me, is if we do have a flu pandemic or some pandemic, it's not like people are going to stop having COPD exacerbations or anything else that goes on.
Oh, yeah.
So I guess your algorithm or whatever it is has to be inclusive of
Oh, yeah.
everything.
It's not just for flu.
And I'm assuming that if a pandemic hits, what if you've got someone who's been hanging out in our ICU for a month or in Kindred, long-term care facility for 2-3 months on the ventilator? Is this kind of algorithm going to be able to kick people off in that kind of situation? I mean, we can get into some kind of interesting.
Yeah. Yes. So a couple things. First of all, I don't think, probably the patient in the ICU who's been, there for a while, maybe awaiting placement or something like that on a ventilator. I mean, pandemics don't just hit overnight. They usually, they escalate over a period of time. So I don't think that's a particularly realistic problem where all of a sudden tomorrow we have to make decisions about patients currently in the ICU that we didn't have to make yesterday. Okay, I think there'd probably be some preparation and anticipation of that. Now, the ventilator-dependent folks in sort of non-acute care facilities, that's an interesting question. And I have to say that because we were addressing our health system primarily, also thinking about sort of how we fit into the region we don't make policies for them. So our state and our public health departments are working on stuff like that, but I don't know. I mean, if someone is, there are a lot of people who are ventilator dependent who are out working, Now, if someone who's in a long-term care facility who's ventilator dependent, who maybe doesn't have much higher brain function or something, a persistent vegetative state kind of thing, plus ventilator dependence, I don't know. Would you take them off the ventilator in order to save somebody's life? I'm not sure.
One of the questions that arise that dovetail into that issue is, back in 2006, we had a very stressful seasonal flu outbreak in that there were a lot of people who came down with post-influenzal pneumonias and also COPDers who came in. And at the time, when I was around, University of Louisville was at a 100% census. More striking was Jewish Hospital, 4 blocks away, which was running at 105% census. And so when I would go over to Round, I would see just a bazillion patients who were in the emergency room, some of whom were our patients who we admitted the previous day and ultimately discharged the next day. They never even got onto a
They never
floor.
wound up in a bed.
So for 2 days they were in the hospital ER and were able to be discharged while we were able to go ahead and get some IV antibiotics or whatever it was that they needed. And I asked at the time, I said, this is Mickey Mouse in terms of the number of people we'd have in a true pandemic. And I said, most other places will have like a pandemic plan, an emergency plan, when all hell breaks loose and you have hundreds of people flooding into your ER. And I asked, what is your plan here? And this ER attending went ahead and put his 2 fingers like this across them, like, I looked at it and said, that's not a plan. That may be a response. And the concern that I have is, while you're doing good work yourself, we're not, as a healthcare system, the United States, as a overall overarching healthcare system, is in no way ready for a hyper-virulent strain of influenza. And that if it did, it could cause a cascade effect of the system failing. And that would be catastrophic.
And I have to agree with the caveat that it's better now than it was a year ago.
Yes.
Okay? There was, in fact, just within the past few weeks, a report to the president from I'm not going to remember the official name of it, but the Scientific and something or other advisory task force or something, about H1N1 and where we are right now in terms of the sort of the clinical and biological details of the virus, the vaccine, the supply of antivirals, preparation, stuff like that, and making strong recommendations for some more system-level oversight and coordination of specific aspects of pandemic response, including resource allocation issues, but lots of other things too. Distribution of, say, antivirals or vaccine, which you send as much to California as you send to New Jersey or Montana. Well, no. Do you send California exactly the percentage of vaccine that they represent in the population? That's what they recommended. So that's, so it's better than it was. But I would say a particular weakness actually is in the health services issue. That is, providing care to those who get sick, outpatient or inpatient. We don't really have capacity in most places to do it, hence the need for a resource allocation scheme. So, yeah.
I like your distinction between when, what was it, demand exceeds supply and demand really exceeds.
Yeah, right. Okay.
One of the worries is that the places where demand exceeds supply are at the relatively okay state they're at, in part because places where demand really exceeds supply are at the really bad place they're at. And I'm thinking of first the importation of healthcare workers from the Philippines or something like that.
Yeah.
So the way we prevent things from going anywhere here is rely on others to educate our economy. So what do we do when there's a pandemic here in the Philippines? Do we send beds, money, vaccine there in repayment for the development assistance they've given to our healthcare system? Or do we say, all bets are off, you got them now, you can't have them, or whatever? And it's not just healthcare, right? One of the reasons that we're going to be so poor is that we're rich. So,
yeah. So so the question is about sort of the relationship that exists between different places and the degree of resource scarcity, and that in fact those with really scarce resources, even at baseline without any kind of a pandemic, are that way in part because other places have more resources or wealth or advantages or whatever and are able to attract personnel or workforce, say, from other countries. And I'd say, yeah, absolutely, that relationship exists. It exists, it's recognized by some folks, but the kinds of sort of repayment things that you're talking about in terms of, oh, we should do something for them because we're taking all their nurses, really doesn't generally happen. We do in the U.S., hey, I'm just kind of telling it like it is. We do in the U.S., however, train a lot of folks internationally. Sometimes they stay here, and sometimes they go home. So in some sense, we contribute to workforce capacity in other places. I don't know. Yeah.
One last question with Paul here.
Oh, yeah. Okay.
Paul.
Actually, I have two parts to my question.
Okay.
The first one was, I'm curious about whether there was any explicit discussion in your community forum about the issue of medical care to non-citizens, when citizenship status making a difference in terms of availability of resources to those individuals, especially perhaps the illegal, how that factors into
Okay, so the question was whether or not there was discussion in the forums about citizenship as criteria for receiving care, resources, or whatever. It did not come up in our public forums. It has been explicitly rejected as a criterion in our health system, and so that's something that really hasn't been issued. Now, I should say, though, that if our health system were like right across the border from another country it might be brought in as an issue, not so much, you know, us versus them, kind of illegal aliens kind of thing, as a sort of, well, they're trying to get something they can't get at home by coming here. So similar, in fact, to the, if I can't get it in Louisville, I'm going to go to Lexington because I can, you know, I've got the car and the money and I know somebody who works there or whatever. And that would be a concern because you want to avoid, if at all possible, that sort of shopping around for resources that happens across communities. So.
The second question was, you work in a healthcare system that has a very large tertiary care hospital that draws patients from around the state.
Right.
Would the administration, or does the administration of the hospital envision itself rethinking its mission in a pandemic to serve primarily local people who might get sick in that community and demand immediate care for ICU ventilator care?
Well, I think as our palliative care colleague pointed out, you don't only have pandemic patients during a pandemic. You have lots of patients during a pandemic. So we're prepared for our usual tertiary care patient population from around the state of Michigan, northern Ohio, and sometimes other places to still be coming for what they need. Now, in addition to caring for sort of a local, to some extent regional population of flu patients, so the more complicated perhaps patients might be transferred to our institution if they couldn't be cared for at a community hospital, say. But that would be sort of the unusual case for flu patients, I think. But we would still have all those others. Those others, so.
So with that, we're going to close. Thank you very, very much.
Thank you. That was fun.